Alzheimer's disease is an active, aggressive biological invasion of the brain's neural networks, distinct from the normal cognitive changes associated with aging. Modern neurology has moved away from defining Alzheimer's solely by a patient's behavior. Today, it is categorized as a specific, identifiable proteinopathy, diagnosed through fluid biomarkers and advanced neuroimaging. This biological definition rests on two microscopic hallmarks: the accumulation of extracellular amyloid plaques between neurons and the formation of intracellular neurofibrillary tangles. These markers allow us to track the disease across a clinical continuum. It begins in a preclinical phase, where a patient is asymptomatic but biomarker positive, advances into mild cognitive impairment, and eventually results in clinical dementia. Identifying the disease during the preclinical or MCI phases is the primary goal of modern treatment. This window offers the only opportunity to preserve functional brain tissue before structural collapse becomes irreversible. The path toward these protein accumulations depends on a patient's genetic profile, which determines whether the disease begins in middle age or much later in life. Early onset or familial Alzheimer's affects patients under the age of 65. It is driven by highly penetrant mutations in specific genes, most notably the amyloid precursor protein, or APP, and presenilin 1 and 2. Late onset or sporadic Alzheimer's accounts for the vast majority of cases in patients over 65. The primary genetic risk factor here is the E4 allele of the apolipoprotein E gene, known as ApoE. This chart illustrates the risk multiplier. While one E4 allele increases risk by 2 to 3 times, patients who are homozygous, carrying 2 copies, see their risk for developing Alzheimer's jump by 10 to 15 times compared to the general population. Genetic research shows that regardless of the initial trigger, whether it is an APP mutation in a 40-year-old or an ApoE risk factor in an 80-year-old, the brain eventually exhibits the exact same protein pathology. This shared molecular outcome allowed researchers to isolate a single, universal target for drug development. The process that destroys the brain starts at the neuronal membrane, which serves as ground zero for the pathogenic cascade. This healthy neuronal membrane contains the amyloid precursor protein, or APP, which normally supports neuroprotection. The cascade begins when beta and gamma secretase enzymes cut APP at the wrong locations. Releasing this 42 amino acid fragment, A-beta-42, initiates the disease. This A-beta-42 peptide is toxic and insoluble. Unable to dissolve, fragments aggregate in spaces between neurons, clumping into dense, obstructive neuritic plaques. This accumulation extends beyond brain tissue, building up within cerebral blood vessel walls, causing amyloid angiopathy. The presence of these extracellular plaques puts immense stress on the neuron, triggering a separate, lethal chemical reaction inside the cell body. If amyloid plaques are the match that starts the fire, the actual destruction happens through the internal collapse of the neuron's own structure. Inside a healthy neuron, a protein called tau acts as a stabilizing pin for microtubules. These microtubules serve as tracks for axonal transport, moving vital nutrients and organelles across the cell. Under amyloid stress, tau undergoes hyperphosphorylation, detaching from the microtubules. These free-floating proteins aggregate into neuronal cytoplasmic fibrils, forming neurofibrillary tangles. Without stabilizing tau, the microtubule tracts shatter, axonal transport fails, structural integrity is lost, and the cell begins to die. The destruction then spreads. Pathological tau misfolds the native tau in adjacent cells, moving through the brain's connected networks in a prion-like fashion. This spread of tau tangles is the direct executor of neuronal death. Its physical path through the brain mathematically correlates with a patient's worsening cognitive decline. The path of this protein propagation creates a predictable sequence of brain damage, beginning in the medial temporal lobe. This initial damage to the hippocampus causes episodic memory loss. As tau reaches the parietal and temporal lobes, patients experience visuospatial deficits and word-finding difficulties. Finally, frontal lobe degeneration results in the loss of complex planning and executive function. Modern imaging, such as MRI, can visualize this structural loss as cortical atrophy that exceeds what we expect from normal aging, but visible atrophy is a late-stage marker. To catch it earlier, physicians use fluid tests and advanced PET scans to find the proteins themselves. A confirmed diagnosis requires a specific biomarker signature. Fluid tests must show decreased A-beta 42 because the protein is trapped in brain plaques, alongside increased p-tau. A PET scan then confirms the presence of cortical amyloid. We can now prove the biological presence of Alzheimer's years before a patient ever fails a memory test. Our detailed understanding of this molecular process has split Alzheimer's treatment into two distinct categories: symptomatic management and disease modification. Symptomatic therapies target the chemical deficits caused by brain damage. For example, the destruction of the nucleus basalis of Minard leads to a massive loss of acetylcholine. In mild to moderate cases, cholinesterase inhibitors like donepezil are used to boost these acetylcholine levels, providing a modest stabilization of cognitive function. As the disease advances, NMDA receptor antagonists like memantine are added. These drugs work by blocking glutamate excitotoxicity, helping to slow the rate of cognitive deterioration in moderate to severe stages. Disease-modifying therapies, such as the monoclonal antibodies like lecanemab and donanemab, function by promoting the direct clearance of established amyloid plaques from the brain. These antibodies are strictly indicated for patients in early symptomatic stages, MCI or mild dementia, who have verified biomarker evidence of amyloid pathology. Medical intervention has shifted from the management of cognitive symptoms to the active removal of the biological drivers of the disease. Clearing established amyloid from the brain introduces a specific radiologic risk known as ARIA, or amyloid-related imaging abnormalities. Clinicians must monitor for two types of ARIA: Area E, which involves brain edema or swelling, and Area H, which involves microhemorrhages and localized bleeding. The risk for severe ARIA is not distributed equally. Patients homozygous for the ApoE4 allele face the highest probability of symptomatic and recurrent complications. Safe management now requires baseline genotyping, followed by a rigorous schedule of MRI safety screenings during the course of antibody infusions. Despite these medical advances, the human cost of the disease persists. Physicians must still address the immense burden of caregiver burnout and the progressive loss of patient independence. The modern management of Alzheimer's requires a high-stakes balance between aggressive biological intervention and rigorous radiological surveillance, fundamentally changing the nature of dementia care.